Good morning. We'd like to start the next session. It's plenary 10, valve 2. We're going to chair this session with Dr. Tawisak. I have the privilege to introduce the first speaker, is Professor Schaff. I have been a research fellow at the Mayo Clinic 25 years ago when I first met Professor Schaff. I never thought I'm going to be in this place now. So please start, Professor Schaff. The title is Understanding Hemodynamics of Mitral Regurgitation, Volumetric Analysis. Please start.
Thank you, Hiro Tawasi. I have a problem because I'm the first one in the session, so I have to stay on time. And as time runs out, if I get towards the end, I may have to skip over a few slides because I unfortunately probably have too many slides. Now, I'll start with this, which is a paper on transcatheter mitral valve repair. And the conclusion is well known to everybody in the audience. Did anybody see anything odd in the paper as a result, as reflected in the assessment of mitral regurgitation? Because if you didn't, and you go along with me on assessing mitral regurgitation in a volumetric sense, you'll read this paper differently. And we're going to talk about mitral regurgitation, but the same principles apply to tricuspid regurgitation or aortic regurgitation. This is a patient who had complex case, previous pericardiectomy, radiation heart disease, had mitral stenosis, severe tricuspid regurgitation related to a pacemaker. And you can see, now this patient, we did a little different. We did a left atrial to LV bypass to get around the calcific mitral stenosis and repaired the mitral valve. And after the operation, the patient's in the ICU still. The left ventricle is good. The right ventricle is not working very well. So what would you say is wrong? We have RV dysfunction due to poor myocardial protection. Maybe we injured a coronary artery. Maybe there's pulmonary hypertension. Maybe there's the odd case of a pulmonary embolus or something else. The next case I'll show you is a patient that had a reoperation for prosthetic aortic regurgitation and severe TR. And you can see the preoperative LV in short axis on the left, and you can see the AR there. The patient had very severe tricuspid regurgitation as well. And then after surgery, this patient's still in the ICU too. And you can see there's no tricuspid regurgitation, but the ventricle's poor. Now, is this RV and LV dysfunction due to poor myocardial protection? Maybe coronary disease that was unrecognized? Maybe LV dysfunction, we operated too late, or something else? So think about those things. Now, to understand or to appreciate the volumetric assessment of mitral regurgitation, we have to go back to what the cardiologists do when they present a case to us. Now, we no longer go by the color Doppler in a sense. I mean, the color Doppler is impressive, but nowadays we do quantitative measurement of mitral regurgitation. It's not necessary for surgeons to know every piece of the formula, but just like the Fick equation, it's important for us to understand what goes into it when somebody says there's a regurgitant volume of 50 or an ERO of 0.3 or 0.4. And the cardiologists do this with Doppler by measuring the radius of the PISA, multiplying that by the aliasing velocity, squaring the radius, and then a constant. And if you know the regurgitant velocity, and you divide the regurgitant flow rate by the velocity, you get an ERO. If you multiply the ERO by the regurgitant time velocity interval, you get a regurgitant volume. And the numbers that we go by when we're trying to say something severe is a 60 cc or more regurgitant volume with an ERO of 0.4. So remember those numbers. Now, we're talking about thinking volumetrically. How is that helpful? Well, first of all, it helps you understand what severe regurgitation is. If you have a regurgitant volume of 60, and you have to stay with me here for a minute, this is simple math you can do on a napkin. If you have a regurgitant volume of 60 and a patient walks into your clinic, they must have a forward output of 60, right? And that means they have a total stroke volume of 120, And if you had a total stroke volume of 120 and an regurgitant ejection fraction of 60, that means you have an end-systolic volume of 200. Pretty simple math. But what does that mean? That means that if somebody calls you and says, I have somebody that has mitral regurgitation with a normal LV, you can say, no, you don't have severe mitral regurgitation with a normal LV. You can have a normal ejection fraction, but you can't have a normal sized ventricle. For example, this is a paper that was submitted to the journal, and the surgeon said transthoracic echo showed isolated posterior leaflet prolapse, regurgitant orifice area 57, regurgitant volume 63. The left ventricle was not dilated with preserved ejection fraction. Now, can that happen? Well, if you think volumetrically, the answer is no. It's impossible to have a normal-sized ventricle and severe mitral regurgitation. And it helps you understand when to operate and when not to operate. This is a 56-year-old woman who was asymptomatic and referred to us. She was picked up by a cardiologist in Florida who had been following her and said she's had bileaflet prolapse. Now the regurgitation is severe. She was referred to a surgeon for a mitral valve repair. He wanted to operate. She was uncertain. She ends up going to 2 additional surgeons in New York. They both advised surgery, but she was uncertain. So she came to Mayo Clinic. She wanted another evaluation. She was asymptomatic, normal BNP. Here's her chest x-ray. You can see she does have a broad jet of regurgitation that you can see on the right side. At least the color is impressive. But this is her transthoracic. These are her numbers. She has an end-systolic dimension of 49. Now, can this person have severe regurgitation? Well, this is her Doppler echocardiogram. What she had that showed that bright Doppler signal was late systolic mitral regurgitation. And when our cardiologist did the quantitative measures, she has an ERO of 0.29 and a regurgitant volume of 35. She doesn't need surgery, or at least she doesn't need surgery now. Now, here's another patient. This is a patient of mine. I did an operation, mitral valve repair, almost 20 years ago. At that time, she had endocarditis, large ERO, regurgitant volume of 88. We did a mitral valve repair with anterior leaflet chordae, artificial chordae and a ring, or partial ring. She did well over the years, but then developed atrial fibrillation and some other medical problems. She developed profound fatigue and dyspnea. And she was referred because she had recurrent mitral regurgitation, severe left atrial enlargement. Her repeat echo at our institution said at least a regurgitant volume greater than 30, and she had a gradient of 8, they said. And this is what the cardiologist wrote. He recommended a mitral valve replacement with a bioprosthesis, tricuspid annuloplasty, and a Mays procedure, and implant a lead, yada, yada. Now, what I didn't tell you was that she had an ejection fraction of 60% and an end-systolic dimension of 45. So think about this one. What's wrong with this person? Well, the first thing we want to do is see whether there's any coronary disease or anything else that could be causing a problem. This is her angiogram. And so we get an LV-gram and say, how severe is the regurgitation? So even with PVCs, there's some regurgitation, but I think everybody in the audience will agree that it's not severe. She had good function at the base of the heart, where you calculate the ejection fraction from. But guess what? This patient had Takasubos. Now, you know, we would have gotten in trouble if we had done a reoperation on a patient with Takasubos because she had fatigue and an echocardiogram suggested that the mitral regurgitation was severe. But understanding volumetrically that you can't have severe regurgitation with an end-systolic dimension of her size kept us out of trouble. Well, if you think volumetrically, it also helps you understand what happens after mitral valve surgery. So here's a patient with mitral valve prolapse, or ruptured cord. And here's what it looks like after surgery. There's the ventricle after surgery on your right, the ventricle before surgery on the left. And I think everybody will say it doesn't look quite as whippy after we repaired the mitral valve. Now, what's the cause of that? Well, some people may say, well, that's increased afterload. Others say, well, you closed off the pop-off pathway. Others say you unmask LV dysfunction from chronic volume overload, poor myocardial protection. And then I've had a few surgeons tell me that it never happens to my patients. Well, it happens to everybody's patients if you look for it carefully. There's another explanation for it. Let's take a patient, and I changed the numbers here just a little bit to make the math easier, but ejection fraction 50%, preoperatively has severe regurgitation with a regurgitant volume of 80, and now that patient walks into your office, so the patient has a forward stroke volume of 60, right? That gives the patient a total stroke volume of 140. We said that the ejection fraction is 50%, right? That means that you have an end-systolic volume of 280. Everybody's with me? That means you have also an end-systolic volume of 140. Now what happens after you close off the mitral regurgitation? You correct it or you replace it, you eliminate the regurgitant volume. Well, when you come off bypass, you still have an end-systolic volume of 280, right? And let's give the patient a larger stroke volume. Let's say you come off bypass and the stroke volume is 100 rather than 80. So you have an end-systolic volume of 280, a total stroke volume of 100. That means you have an end-systolic volume of 180, and your ejection fraction is 36%. So what happens when you correct a regurgitant lesion is that the body adjusts to give you a forward stroke volume that's appropriate. Maybe it's higher than normal, but that may mean that your end-systolic volume is increased and you have a decreased ejection fraction. And we've looked at that in patients after mitral valve repair. Immediately after mitral valve repair, there's no change in end-systolic dimension, or very little when you come off bypass. I mean, it's still an enlarged ventricle. But you do have a reduction in ejection fraction, and that's not due to poor myocardial protection, because if you compare it to patients that have bypass surgery, there's a slight increase. But there's an increase in stroke volume. So when you correct regurgitation, you may notice a decrease in ejection fraction, but that has nothing to do with the pump function. We think that the ejection fraction decreases primarily to an increase in end-systolic dimension, and that that's a compensatory mechanism to prevent augmentation of stroke volume. So we know what happens after regurgitation, after correction of regurgitation. What's the difference? This also helps you understand ischemic mitral regurgitation. And here's another case. So this is a patient with dilated ischemic cardiomyopathy, ejection fraction 30%. Everybody would say that's severe? All right, and the echo report says a regurgitant volume of 82 and an ERO of 0.48. But wait a minute, the ejection fraction is 30. Do all those numbers add up? Or what would you do? Well, first thing to do is get a coronary angiogram, and it turns out that the patient had a nice result from previous surgery. Terrible native disease, but a nice mammary. Had a vein graft to the PD that looked okay. Probably lost the OM graft. What next? Well, if you think volumetrically, you look back at the echo and you say those numbers don't add up. We need another assessment of the mitral regurgitation. Why? Well, you can't have an ejection fraction of 30% and a regurgitant volume of 80. Let's do the math. It means you have an end-systolic volume of 200. You have a regurgitant volume of 80. The patient still walks into your office, so they have a forward stroke volume of 60. That gives a total stroke volume of 140. And if that's true, you have to have a ventricle that's out to here. That's way too big. It can't happen. So what we did in this patient is we got a ventriculogram. Ventricle's poor, but there's only a puff of regurgitation. So if you think volumetrically, it can keep you out of trouble. Now, I wanted to get back to this paper, which is the MitraClip paper, because once you get into this thinking volumetrically, you don't read a paper on mitral regurgitation the same way. Now, these are the results that nobody can read from even the front of the room, but I'll blow them up for you. This is what they showed. They said in the treated group and the other group, the ERO was 0.4. Are you with me? And remember we said that that corresponds to a regurgent volume of 60, correct? All right. Now, they said their end-diastolic volume in each group is about 190, and their end-systolic volume is about 135. Now think about that for a minute. That's total stroke volume. Now if you have a total stroke volume of 60, how much can a regurgent volume be? Can't be 60, that means you got nothing going forward. If the volumes are correct, the most regurgitation you could have in these patients is about 20, if the volumes are correct. Now it could be that the volumes are incorrect and that the ERO is correct, but one of those numbers is different, is incorrect. So to get back to those two patients that I showed you earlier, this is the preoperative right ventricular, this is the preoperative RV function. The stroke volume was 66. Even though the ejection fraction looks worse, the forward stroke volume post-op is 93. And the same way in the patient with AR and tricuspid valve repair, preoperatively the ventricle looks pretty good, post-operatively not so hot, but the forward stroke volume was 43 before surgery and afterwards is 72. So remember, the numbers have to add up. It's not rocket science, but if you go through the numbers, they have to add up. We believe that the ejection fraction declines early after correction of mitral regurgitation or aortic regurgitation or tricuspid regurgitation, and that it's a compensatory mechanism. And the recovery of ejection fraction depends on remodeling or reverse remodeling of the ventricle. We didn't talk about this, but multiple moderate lesions produce severe volume overload as well. Thank you.
Thank you very much. Any questions or discussion from the floor? I think the volumetry of the ventricle is quite tricky because the echocardiogram will not always tell the accurate volume, and then in the clinical sessions, echo is kind of a gold standard to decide what to do. Please.
Scott Rankin, I really enjoyed that, and as you know, we've been interested in this for 40 or 50 years. John Spratt did an animal study with a conduit from the left atrial appendage to the left ventricular apex in a wake animal with crystals and everything, and he could occlude it immediately in one beat. Showed the same thing. The forward ejection fraction goes down, but the forward stroke volume should go up. The pump function should improve. In recent years, we have been using more the magnetic resonance to look at volumes and regurgitant fractions. What's the role of that in your practice now? Is it more quantitative, do you think?
Just as easy to get a left ventriculogram. Yes, Chris.
I try to draw those in the OR to explain, think volumetrically my resonance as well. Sometimes, somehow I always mess up the numbers, but you always get it right up here. I like how you wove coapt into that. I'm trying to think of an explanation how the numbers don't add up. Is it possible that if you think about regurgitant fraction, half is going forward, half is going backwards? So if it's a regurgitant volume of 30 and 30 is going forwards and the patient's tachycardic, is that compatible? Would that be compatible with life?
That might be, but and our assessment of mitral regurgitation gets a little complicated because we talk about regurgitant volume and we talk about stroke volume and then we talk about regurgitant fraction, and then your head starts spinning. But the two numbers have to add up, the amount that goes out the aorta and the amount that goes backwards. So yes, if the patient could be alive with a regurgitant fraction of 30 and a forward stroke volume of 30, then that works. But that's not compatible with an ERO of 0.4. That's the point. And I don't know which one of those numbers is wrong, but one of them is wrong.
I think it certainly is a sort of walking talk, but in a critical practice, I think we are operating severe MR with normal-sized ventricle. But we have to think about deeply. Thank you very much. And I want to introduce the next speaker is Dr. Patterson. The title is Surgery for the Infective Endocarditis, Complication with Embolic Stroke, Timing and Disease. Decision.
Thank you. As you can see already on the title slide, I have included a neurologist and a neurosurgeon, and you know, this is a difficult topic. And my main purpose with this talk is to make you get the sense of how difficult this field actually is, and that we as cardiac surgeons seems to think about this in a very simplistic way and do not understand all the different implications of these neurological complications in infective endocarditis and how they compare to other neurological events which are not related to endocarditis. If you want to know more, you can come to our symposium. That's the only disclosure I have. We have a symposium that really emphasizes the team approach to endocarditis, and that this is a multidisciplinary effort, that you really need a complete hospital to deal with patients with endocarditis. So we all know that neurological complications are very common, and depending on how you diagnose them and how you define neurological complications, you can end up with that this occurs in over 60% of the patients, and of course the later we get the patients, the more neurological complications we will identify. And they represent the septic emboli, and they are let's say a marker for severe and advanced disease. And we all know these correlations, that large vegetations is associated with embolism, mobile vegetations on the anterior mitral valve leaflet, the organism being Staph aureus, and Dr. Desai at the clinic did a meta-analysis that really confirmed these things. I was involved in this overview center paper, which is a review paper on neurological complications, and you can see that most of these complications are ischemic stroke. Intracerebral hemorrhage is about 10%, subarachnoid hemorrhage 5%, meningoencephalitis 5%, and some abscesses and some infectious intracranial aneurysm. And I will talk a little bit about most of these. Once again, to emphasize that this is a marker for severity of the endocarditis, also a marker for timing. If you do keep on to this patient and don't get them diagnosed on time, or don't refer them for surgery on time, or the surgeons don't take them to operating, you will move on this scale, and the patients will be more severe. So it's a matter of also how our clinical management, how many patients will end up in each bucket. And as we anticipate, intracerebral bleeds is of course associated with worse outcomes, and we don't see that many in meningoencephalitis cases. So I don't really know a lot about that. Again, many of these are considered asymptomatic, and it's of course always a definition about what is asymptomatic and who say the patient is asymptomatic. Is it the patient, the surgeon, or the neurologist that thinks they are asymptomatic? If you really look for them and evaluate the patient's mental status, of course, many of them are not asymptomatic. We also all know that once you start antibiotics, the risk of additional emboli quickly goes down, and if you go beyond 2 weeks of antibiotic treatment, very few cases will happen. Acute stroke, how do you approach them? What treatment options do we have? And IV thrombolysis is one option, and that could be for a patient with atrial fibrillation and an embolus to the brain. Thrombectomy is an alternative. That's for a young patient who had, say, an embolus to the MCA and had that extracted and got reperfusion of that area. Thrombolysis is, as we can anticipate, associated with a risk of post-thrombolysis hemorrhage, and that is, the risk is higher if the patient is an endocarditis patient than if it's not. Thrombolysis versus thrombectomy. You can see that thrombolysis is associated with hemorrhage and not really something that's widely applied to these patients. Just want to emphasize that MRIs detects a lot of asymptomatic, what we call asymptomatic lesions, and if they are asymptomatic, the risk of postoperative complication is very low, and some people have argued that, yeah, we really don't have to do brain imaging in patients who are asymptomatic. I would certainly disagree with that, because it's not always innocent findings that you have, even if the patient is asymptomatic. And we've also seen that there are several papers that claim that early surgery does not increase the risk of hemorrhagic conversion. And one of the main conclusions of the Kang paper in New England Journal of Medicine was that a lot of these patients had large vegetations, and if you don't operate on them early, they will have additional embolic event. Intracranial hemorrhage will be the next topic, and of course that is more serious. 5 to 12% have that, and it's intraparenchymal, or it is subarachnoidal hemorrhage, and it's associated with mycotic aneurysms, and another group is hemorrhagic transformation of ischemic strokes and microhemorrhage, and I'll address a little bit of those. Intracranial hemorrhage, there's this paper by Yoshioka that had 30 patients. You see how they are divided on parenchymal hemorrhage, subarachnoid hemorrhage, and hemorrhagic infarction, and the way they handled these patients and operating on them. No one had really any severe neurological complication afterwards. Hemorrhagic transformation occurs in a large number of embolic stroke, and that's something that we have a lot of discussion about. So what is the implication with regard to timing of surgery of that? You see, it's actually the majority of patients who have ischemic stroke who has some kind of hemorrhagic transformation, and when you have mortality associated with ischemic stroke, most of those had suffered hemorrhagic transformation. They did not see any predictors of hemorrhagic transformation. And you can have hemorrhagic transformation in different ways, and this is to say an important slide, that if it's a small petechial hemorrhage without any significant space occupation, that is of course considered benign. If it's in a more severe form of parenchymal hematomas, of course the significance is quite different. Hemorrhagic transformation, you can have different forms and shapes and severity, as we've already mentioned, and it's a consequence of changed blood-brain barrier permeability and dysfunction of the vasculature, and there is some sort of explanation for when and why this happens. It is associated with intracranial, now we go to the microbleed instead, which are, let's say, tiny spots of bleeding. These are associated with increased risk of intracranial hemorrhage, and if they occur with acute stroke, it is associated again with postoperative bleeding. But and it may be associated with intracranial aneurysms. But we still really don't know the significance of these microbleeds. Subarachnoid hemorrhage, of course, is a serious thing. Mycotic aneurysm, the neurologists and neurosurgeons don't like the word. The word mycotic thinks that the mechanism is a fungus, and it's not really has anything to do with that. So they would like to call it infectious intracranial aneurysms, IIA. And say how common this is with endocarditis, we really don't know. We really don't know, so say, how aggressive we should be in our screening for this. The mechanism is direct bacterial infection, embolic occlusion of vasa vasorum, or immune complex disposition. It represents 5% of all intracranial aneurysms, and 3 to 10% of patients with endocarditis develop infectious intracranial aneurysm. It takes much longer time to say than mycotic aneurysm. Presentation with intracranial hemorrhage or subarachnoid hemorrhage is associated with a high risk of infectious aneurysm being present, and in others and our experience, when you screen patients with angiography who do not have any bleeding in the brain, the yield of angiography is very low. They can have really any location. Most often they are peripheral. MCA territory is the most of them. Posterior cerebral artery territory is about a fifth, and many have multiple locations. They are associated with viridans and aureus, but that's not the only organisms that can be associated with this. And if you have an infectious aneurysm, the mortality associated with endocarditis is high, and of course, if you have a ruptured, it's very high. But size is still not a reliable predictor of rupture, even if you would anticipate that. This study by Core in 1995 is a study which is interesting because it has serial angiograms during the treatment, and he wanted to study the response to antibiotic treatment alone. You can see what kind of bleeds there was. And during antibiotic treatments for 6 weeks, there were no new aneurysms detected. You can see that a third of them resolved, a third of them remained unchanged, and some decreased in size and some increased in size. Antibiotic treatment, you can see our series 2011 to 16. It's in the lower line here. We had 25 cases, 7 of which did not have any follow-up imaging, and you can see that We had resolution in only 7 of residual 18 cases, while the other cases were either the same size or worse. What's the predictors of bad outcomes? Saccular aneurysm and shorter duration of antibiotic therapy were predictors in this study. So the role of neurosurgery, they do, say, endovascular and open to this. They can say clip, they can coil, they can embolize, and we had a very interesting presentation by our neurosurgeon. It was so complicated, and these pictures are so difficult to interpret, so I didn't dare to include a lot of them because I wouldn't be able to interpret them myself and point to the right aneurysm. So I refrained from that. But they have a lot of tools in their hand to manage these, and they have, so to say, different. Often they are very distal and difficult to access, and we think about them in a simplistic way. They think about in a way that how can they approach it. Do I have 5 more minutes, or is it? I think we started at 15, and so the endovascular management is of course preferable because it gives you less waiting time, and usually if the neurosurgeons have been successful in addressing it, they have really told us that we can operate the next day without being punished for it. This is one example that we had recently together with neurosurgeons, and he had a bleeding, and he had this aneurysm on the first, and of course you can see that it's in a major artery, and you can't just sacrifice that artery, so they were conservative initially, and it grew in size, and it grew even more in size, so they said we got to do something. So we treated them with antibiotics, and then they actually did an external carotid to middle cerebral artery bypass and excised the aneurysm, sacrificed the artery. So when you talk to the neurosurgeons about this, this is a very variable presentations of these, and very, very variable locations, and there is no real widely accepted management scheme for these patients. But they still do a lot of endovascular interventions on these patients, and sometimes they do open surgery. You've already seen that. So what's now the implications for the timing of surgery? How should we use this when we see the patients with the neurological complications? You can say that the guidelines for many years were really guided by this multi-center Japanese study that showed that if you waited 1 to 2 weeks, the risk of making the cerebral symptoms worse had really come down to a baseline, and so that's the timing we had. Now we are much more aggressive with regard to the endocarditis, and this was, so to say, a little bit of a summary of how we looked at this when we wrote the new guidelines for treatment of endocarditis for ATS. I've repeated many times that in the time interval from when you first see the patient until we operate the patient, if the patient has a severe valvular lesion, so nothing good is happening. So that's really a period when you invite more complications and you see more patients. So, and surgery removes the source of embolism. That was really what Kang said. So we're not dogmatic in any way. So we discuss with everybody involved and the neurologist involved, and so if a patient has severe neurological symptoms and is unconscious and don't respond to command, and so then we don't take those patients to the operating room. So they have to have a reasonable, we have to believe in a good neurological prognosis to operate. A question again, so say what to do with the screening. Should we screen everybody, and what's the meaning of asymptomatic lesions? We do think that there is a low risk of making the brain symptoms worse and making the stroke worse. And I think there's more evidence now that if you look at this in a sensible way, you should be more aggressive and operate. You saw these data once again, and once again there are sort of more literature out there to say that the risk of early surgical intervention on the heart is not that bad. We do want to have imaging, and if there is a long interval between the first imaging of the brain to the repeat imaging, then we would, to the surgery, then we would repeat imaging before surgery, and the new technologies for diagnosis of aneurysm are of course more sensitive, but they still aren't perfect. So we do digital subtraction cerebral angiogram if they have significant bleeding in the brain, but still the yield is not that high. But if you don't have, this is just to repeat that, our rate of finding infectious aneurysm has been 5 to 9% in the patients we actually bring to subtraction angiograms. But we still think that there is a fairly low utility in screening everybody with stroke. So once again, I think we can go to, I don't think we can do much more. So we have an algorithm that we use and how aggressive we are with our imaging, and this is what we do. If we have small or moderate size stroke without hemorrhagic transformation, we go to surgery. For those with larger stroke and hemorrhagic transformation, we have a thorough discussion about risks and benefits, and we, so to say, still wait on those with significant bleeding, but sometimes the heart problem is pressing, and we are pushing this time limit down. Okita talked to us about neurological complications on our last master class, and they have experience with nafamostat mesitylate during cardiopulmonary bypass with improved outcome. We have not tried that, but that's of course something we could do. Again, cerebrovascular events in infectious endocarditis convey urgency in aggressive treatment with antibiotics and surgery to treat the source of infection and further embolism. And today we have no automatic contraindication, but a multidisciplinary approach to the decision making. Thank you.
Thank you very much, Dr. Patterson. This is a nice overview and then clear, I think, conclusions for me. Is there any questions, please?
What a great review, really complete. And, we did a study, Jeff Gase, who was the first author in the STS database a few years ago, and showed that the presence of a asymptomatic cerebral lesion preoperatively really, in a multivariable analysis, had no effect on outcome. And so we got very aggressive with operating on these patients like this. I had a patient, though, that had a Candida mitral endocarditis, and she had some minor lesions in her brain pre-op, and we operated on her, replaced the valve, and according to the International Collaboration on Endocarditis guidelines, we kept her on chronic new generation antifungal like Candace's. And she did great, and we're patting ourselves on the back, and about 4 months post-operatively, she ruptured a mycotic aneurysm in her brain and died. So two questions. One is, does the organism have an effect on how aggressive you are? If you have a fungal endocarditis or something like that, would that make it different? And then secondly, how do you follow these patients up? Have you seen late problems related to it?
Yeah, to the first question, I don't know the answer to that. We have the same experience. I have personal experience with a couple of patients with Aspergillus with mycotic aneurysms in several places in the body, and of course that's an extremely serious problem. We have the same approach. We operate on them, and we treat all the lesions they have, and we keep them on antifungal for life. I think that is more or less standard. One interesting observation is that the neurosurgeon Bain here claims that there is no reports about the foreign material that they put in on these patients get infected, which surprises me. If you think you have an infected lesion and you fill that with some embolic material, or you put in a stent or a coil, you would anticipate that wouldn't work, but it obviously does. But one thing that I have learned from the neurosurgeon is that this is very dynamic and they change. And he showed many examples of patients with kind of aneurysm that I showed this 50-year-old here, that there changes and lesions, so say, come and go during treatment. And I think that they are still in a learning phase. What should we do, and when should we do it, and how should they be followed? I don't think we have the answers yet.
Professor Patterson, first of all, I thank you for accepting to talk in this very challenging topic. And this topic I used to discuss with Professor Okita about the timing.
Yeah.
And we know that the very dilemma between when the bleeding, intracranial bleeding, a stroke occur, either infarction or bleeding. And then what I learned from him is that if the infarction, we may go ahead right away. For the intracranial hemorrhage, now he may find a way to reduce the potential risk of bleeding from the standard way of cardiopulmonary bypass by special type of the anticoagulation. Could you elaborate about this way of how to do that if we have to do early intervention in this particular group of patients?
I don't think I dare to do that, but I have Professor Okita's presentation on my computer if anyone wants to see exactly what his protocol is. So I have that for you if you want to, but I wouldn't dare to elaborate on it myself. And I don't say, no, it's not. It was effective, and I think in his series, and so it certainly seemed to work. I really don't know why we should possibly get some own experience of our own with it.
Thank you very much. I'd like to introduce the third speaker, is Dr. Tawisak. The title is Rheumatic Mitral Valve Repair, the Holistics and the Physiological Approach. Please start.
Thank you very much, Professor Yamaguchi. Thank you very much for your presence here, and then allow me to share some of my experience about rheumatic valve repair, which is actually a very challenging topics, because all we know that rheumatic valve repair in the past, in terms of overall, the result is inferior to the degenerative, which is actually true because of the very complex structure and the region. But anyway, we face a very particular group of patients, which is young. and live in rural area. And we have to accept that the healthcare system in many countries in this part of the world is still not optimal. So we are trying our best to improve the standard of the repair, and hopefully we can, with more understanding and more improvement of the technique and approach, we may allow us to do a better job for this particular group of patients. I'm trying to do during the last several years. And then I would like to start by trying to understand the anatomy first. I believe that anatomy is built with purpose by nature. And sometimes we still do not know, but by any technology. But imagination is very important for understanding by thinking, analyze, and this understanding is crucial for technical approach to restore normality of the lesion. And I believe that with all respect to the nature, the repair will endure. And this is actually is something like told us by Albert Starr, imagination is more important than knowledge. And usually the proven scientific data has been followed the imagination. This is true. If you look back several hundred years ago by Da Vinci, in his understanding, before we understand this type of the anatomy, his drawing in the past several years ago without any echo and the formality of the anatomy allow us to understand that actually some domes look like the leaflet and coaptation and the four leaflet. All of this by imagination, and it's proved to be true later on. And then this structure has been understanding that it creates a lot of durability in Barcelona. It's a very, I suddenly forgot the name of the very cortex, very durable because understanding of this type of the nature. And then I think that we have to aware that the mitral valve is quad leaflet. It's not just the two leaflet. And this small commissional leaflet was built to fully open so that there's the maximal flow during the diastole. And actually, it moved perpendicular with the anterior and posterior. And when it closed, the combination of this small coaptation zone will provide, in summation, the maximal coaptation, which provide the most durability of the valve. We have to try to understand all of this fact, and then, and the structure of the cord is here, is a fan shape, so that it can provide this movement, but spatial movement. And we must try to recreate it back because the rheumatic process disturbs this type of the normality of the anatomy. And then the annulus, although we now know, anterior is strong, but can be dilated. Posterior is less strong dilatation occur there. And dynamism is important, and this saddle shape is also important because the diastolic is so low down to improve the flow, so that the mitral orifice improve, and in systolic is move up for our better closure, is open the LV tract, so that we have to understand all of this dynamism of this saddle shape. And then it will refer to the type of the valve ring that we are going to use. And the annulus is not planar, saddle, anterior is curved. Curve is important because it allows the further movement and mobility of the anterior leaflet, which now we know is an important tool, structure that can reduce and open the orifice better. And this dilatation occurs more on the posterior. And also, one thing is we have to understand that it's not just dilatation. In rheumatic, it can be deformed by several and complex lesions of the rheumatic inflammatory response. So that the framework of like the door in this, we need to restore it back with proper type of the valve ring. If it's too severe, stronger valve ring. If it's less severe, trying to maintain the dynamism of the annulus is the key. So with all of this, and then we have to understand the valve work like an orchestra, a 6-component LA, annulus, leaflet, cord, papillary muscle, and nerve. And each one beat alone need to have this type of 6-component working closely. And the flow is like that. The anterior end-systolic, it needs to be fully open. That means there must not have any obstruction. The cord must be pliable to allow fully opening. The leaflets must be pliable so that the flow can come down like that. And then in systole, the leaflet must be pliable and the cord must not be restrictive. So the cord must not obstructive in diastole, must not restrictive in the systolic phase. So any disturbance of this, we must try to restore back as holistic, not just commissurotomy, papillotomy. No, we have to think several factors and try to restore one by one, and then combine like a normal leaflet back. And then you can see that when it is not just only the coaptation alone that reduces the stress. The cause was built 3 types, primary, secondary, and tertiary. Each one has its own function. Primary cord needs just the level. When it comes to close, pressure buildup, it is a secondary cord that holds the strength, and tertiary cord that bear the geometry of the annulus. So, and to reduce the stress upon the primary cord, it needs a lot of things. First, the secondary cord. Coaptation is the key, has been very documented by Professor Kapongte. And also, the billowing of the leaflet, when it's bowing up, this one further absorbs the tension upon the primary cord. And then that is why restoration of the pliability of the leaflets is one of the key, and peeling come to play in order to provide a better pliability of the leaflet. And when rheumatic comes, it's like a bushfire, like an endocarditis fire, burn everything. And the residue is just unpredictable, totally burned, partially burned, damaged, bent, everything. So one by one, we need to restore it back. And then the target is commissure, cord, subvalve, leaflet, and annulus. So we must understand and provide the technical technique to restore one by one, and then make it back into the normal mitral valve. And this is the same principle, but with a different pathology. We need different approach and technique. Like we learned from the Western country, the US, the European country, also the Barlow. Now come back to rheumatic. We need the same thing, provide the full opening, coaptation, remodeling, but pathology is different. Technique must be different in order to be effective. So repair strategy is still the same, but how to restore? We have to stress on rheumatic valve repair. We need to restore the diastolic phase back. That means fully open, fully commissurotomy, respect fan shape of the commissure, no obstructive movement at all at the cord level, resect any obstructive cord, and improve diastolic flow by restore fenestrated channel between cord and pliability of the leaflets by peeling. This one. When we cut it back, all of this is restored, thicken. We have to cut it so that it move up, peel it, so that it's fully open, no obstruction. The flow will be maximized. So type 1, resect any restrictive cord. Coaptation must be by resect secondary cord, pliability, and remodel of the annulus. Complete, semi, or totally rigid come to play, depend on the pathology of the annulus. And when it's systolic, it's peeled, you have to peel it, you have to cut it, you have to use the coaptation so that it bulge up, provide the angle for coaptation, and better coaptation come back. And coaptation, we need to understand, we normally need coaptation of 5 and coaptation in the inflow and surface coaptation maximal. But rheumatic, we cut a lot of secondary cord. That cord hold the tension away from the primary cord. So that at the end, the ring come to play. We must increase the coaptation zone so that to compensate for any loss of coaptation. And that's why the primary cord will be more durable. And this is one. So I think that the fan shape also is the key of doing any chordal replacement. We have fan shape at the rim so that it bear more, distribute more tension and support more area. And now the rough zone come to play. Why we have to have a rough zone? A rough zone is the combination trying to combine each chord force at the free edge into one, so that it further reduce the tension upon each chord that has happened to the natural mitral valve. And then this one. All together, we come to tackle this one of the cases. It's very severe calcified MS and very severe commissural fusion. The rule of thumb, open first the commissural, doing that and try to restore the fan shape of the leaflet. Calcium, bad guy, cut it out. We need to cut it out because by itself is obstruct the flow, and it restores some, it signifies some very complex structure we need. You see that although this secondary cord, we need to cut it out. And then, not just that, this fuse of the fenestrated channel need to be opened by fenestration. In this way, we can have the transverse movement and the better channel of flow during the diastolic. And all of these are carefully trimmed off, and using sharp resection by the 15 blade, we finally, usually we can find the plane of this. And further using the fenestration plus papillotomy, we can improve the pliability of the leaflet and subvalve structure. Peeling is something that we learn most from Sampat Kumar, and then we modify something and make it very aggressive, trying to peel up to the rough zone. And then we cut at the rough zone like that. And you can see immediately that the leaflet tissue beneath is so good. And then it will do the job better. If we cut all of this type 3, all, then we have to restore it back by chordal repair sometime. It's easily be done by the cortex. And then put in the ring, the appropriate ring, and then you can see that this ugly valve come back again. And you have to understand, we do in the young. They are subject to a lot of long time in their life. And then we can restore it back in the holistic manner. That means, hopefully, with this understanding and improvement of the technique with long-term follow-up, it allows us, in this part of the world, a cardiac surgeon, to do the rheumatic valve repair in the better result. Thank you very much.
Thank you very much, Dr. Tevsak. Is there any questions from the floor? Please start.
Once again, great presentation. I've learned so much. Rheumatic repair is one of my favorite operations I've had. One question, though, for a long time about it, and I thought when I have the expert here, I could ask the question. What's the role of secondary antibiotic prophylaxis in these patients? Do you keep them on chronic penicillin, or do you just use it when they get a sore throat? Or how do you manage secondary antibiotic prophylaxis?
Yes, thank you. We just follow the guideline of the joint agreement between surgeon and cardiologist, the prophylaxis. Usually in Thailand, if there's just nothing, just only the rheumatic with previous rheumatic fever, we will give prophylaxis up to 40 years old. But if they have some infective endocarditis or severe repeated rheumatic fever, then lifelong prophylaxis.
Yeah.
Yes.
One technical question. I mean, we described also our experience in rheumatic patients years ago, and we see really very well on your video that the rheumatic process on the posterior part stop at the level of the secondary chorda. When you resect the rough zone, usually the secondary chorda may play the role of marginal chorda. So we never cut, I personally, I never cut the secondary chorda on the posterior leaflet. I left them intact and they play the role of marginal chorda. Only resecting the rough zone on the posterior and you stop at the level of the secondary chorda and that's all. So I don't feel that there is, we need to resect the secondary chorda on the posterior part.
Yeah, that is a very technical, very question about the technical issue. Now we know that the leaflet in the posterior is a strap. And rough zone usually in natural is about half of that. The primary chord come in, and secondary chord, and tertiary chord. And from time to time that we know that it's retracted and we leave it, it will be like this. The angle will be like this in the posterior. It's drawing down, tip up. And then the coaptation is not good. Until we cut it back, it spring up, then we restore it down. Then it will be the very good buffer for the coaptation, for the entlia. And then we usually now, based on this, we are not reluctant to cut it. We rely on the improvement of coaptation. We know that, as I told you, that the second course was built to hold the tension. Why we know that? We resect the pig heart. Second course always thicker than the primary cord. That means it's just like a body build. Hold the tension every day. You cut it out, the tension will transfer to the primary cord immediately. How to save it? When you cut the nature out, improve it by coaptation, by making the angle using the ring. Then the coaptation increase. Then the reduction of the stress occur. And hopefully, this will restore the durability of the leaflet.
So do you think that the Gore-Tex or the artificial chorda you implanted on the posterior are longer than the secondary chorda? I mean, why, if the secondary chorda are normal, should we resect them?
It's usually when we resect, we see the pathology is thickened and shortened and angulate and disturb the normality or configuration of the leaflet. Then we are no reluctant to cut it. Now, to put in the cord at the primary zone and put it in the rough zone, that is a key because it will form up the team of the other cord, distribute the tension along the free edge. Now, when this cord is come, without restriction of any secondary cord, the bulging of the pressure will even provide the bulging of the posterior and lowering down, provide the maximum coaptation. This is our observation only.
Good morning, Dr. Tavisa.
Yes.
It was really refreshing to hear your lecture after 2014. Just two questions. One is a technical question and one is a post-operative management question. Do you find a patient who has already undergone a balloon mitral valvuloplasty, who you are undergoing a repair now, to be more difficult? And secondly, what do you do for a patient who has a significant calcification near the annulus? How do you do a repair for those? And second thing is regarding the post-operative management in a patient who has a atrial fibrillation and who is post-operatively also having atrial fibrillation. Do you give him vitamin K antagonist or you can do a NOACs for these patients?
Yeah, thank you. The first question is related to the redo post balloon when they're young, coming back still young. In the past, we chop out something like more than 80%. When we gain more experience about doing the calcification and CVS of valve, we found that we can repair it back to 80%. So it is the pathology will be more difficult, especially in subvalve, when it become restenosis. But we'll have some additional problem on the anterior when it comes with the post-balloon MR, because the tear will usually go into the anterior. And in this case, upon repair of the cleft, sometimes we have to do the augmentation of the anterior. So mostly we do something like that. It's more difficult, technically more demanding, but usually at the end we can repair. Now, coming back to your second question about what is
Anticoagulation. If the
anticoagulation in AF. At the beginning, we are very aggressive. I know my friend, Yamaguchi, do the AF everyone. And we used to do like that. And then we found the result is not very rewarding. I mean, more than 50%, around 50% coming back, if the LA is more than 5.5 to 6. So we just try to preserve over time to do the good job on the MV, and then to close the LA appendage if it's needed, and that is all.
But what do you prefer, a vitamin K antagonist or a NOACs?
Oh, I still use the warfarin, the anticoagulant warfarin. Yes.
But do you have any experience of using NOACs in these patients?
No. I think I come across the literature and try to just wait and see for this valvular heart disease.
Okay, thank you.
Okay. Thank you very much, Dr. Stausak.
The next topics will be which is one of the very interesting one, complex tricuspid valve repair, which is, I think, is one of the hot issue now. We will cover and present to us by Professor Yamaguchi, a good friend of mine, who have been associated in several workshops and including training of his young people. We have the MOU, we're sending our people to his. And during his professorship time, I met Professor Schaff in the celebration of this huge hybrid OR as well. So, Hiro, please.
Thank you very much, Dr. Tausak. It's a kind introduction. I have talk about complex tricuspid valve repair. And this slide showing the number of the tricuspid valve surgery in my country in the last 15 years. As you can see, in the last 10 years, the number of the tricuspid valve surgery is increasing. It's now plateaued around 5,000 cases per year. The mitral valve surgery in my country is about 10,000. So, which means tricuspid valve surgery is half of the number of the mitral valve surgery in my country. You can see, if you compare the number of tricuspid valve surgery in 2005 and 2015, you can see the number became almost double. This tendency is also true if you look at the concomitant mitral and tricuspid valve surgery in my country is now about 42.5%. These big changes of wave are supported by the guidelines. And most surgeons thought it is better to treat more than mild functional tricuspid regurgitation if the tricuspid annula is dilated or had a history of congestive heart failure or patient had atrial fibrillation. The mechanism of tricuspid regurgitation has to be assessed by the component classification, same as the mitral valve. We first talk about type 1 treatment. There are several ways to treat the type 1 tricuspid regurgitation by the suture technique, like K or the Vega, or the ring or band annuloplasty using the rigid ring, flexible band, or the 3D rigid ring. About 15 years ago, I compared the efficacy of the suture repair and then the flexible band repair, looking at the residual more than moderate TR and then the recurrent TR at the follow-up. As you can see, the suture repair had the higher incidence of recurrent rate, about 20% in a 5 years' time, and which is reduced to about 8% with the flexible band. The same result was supported by the Dr. Tyrone David group with much longer follow-up. They showed the link annuloplasty is superior than the suture repair in terms of prevention of the recurrent TR and even improved survival. In 2006, the Cleveland group showed the normal tricuspid valve shape is three-dimensional. And that three-dimensional shape gonna be disappeared or affected with the progression of TR or the tricuspid annular dilatation. With the presence of significant TR, the shape of the tricuspid annulus became flattened and circular. To treat those significant TR, three-dimensional tricuspid annuloplasty was appeared. About 10 years ago, I looked at our own experience with the 3D rigid link. We had 481 annuloplasty with 3D rigid link. The 99.2% were concomitant procedure. The 30 days mortality was 1.9, and then hospital mortality was 3.3, which is not really good, but probably acceptable for the patient with heart failure. The significant TR was nicely treated with the 3D rigid link. The link implanted in my unit was the average of 28. We looked at the recurrent moderate TR, and then 5 years freedom from moderate TR was about 95%. So if we put that information together with the previous study, the 3D shaped rigid link had the best result to control the residual or moderate TR. We looked at the preoperative factors in patients who had recurrent TR, and then we found the risk factors for the recurrent TR, including the preoperative AF, severe RA or RV dilatation, low ejection fraction, redo surgery, rheumatic disease, and hemodialysis. So we could summarize that the high-risk patient for the residual TR was who had the severe RA or RV dilatation. And the high-risk patient for the recurrent TR was patient who had the severe RA, RV dilatation, who had a preoperative AF, rheumatic origin, RV dysfunction, redo surgery, and the hemodialysis patient. And further, we looked at the initial mechanism of TR in patients who had the recurrent TR. As you can see, the patient who had the type 3A or type 3B mechanism in addition to the type 1, those are the high-risk patients for the recurrent TR. Let's look at the patient who had the type 3A mechanism. The typical case which caused the type 3A mechanism is pacemaker lead induced. The pacemaker lead is commonly attached to the septal leaflet, which restricts the movement of the septal leaflet. In this patient, the pacemaker lead was detached from the leaflet and the subannular apparatus, and then cutting the commissure between the posterior leaflet and then the septal leaflet into the tricuspid annulus, and then embedded the pacemaker lead behind the tricuspid annulus. Of course, the septal leaflet was damaged, so we need the additional procedure for the leaflet. And normally, we close the commissure between the septal leaflet and the posterior leaflet. I normally use a 6-O-fluorine to close the commissure. And then the 3D rigid ring was implanted. Sorry. In this patient, mitral tricuspid annulus was not enlarged so much. So 28 millimeter ring was chosen, and the water test revealed remnant tricuspid regurg. So additional leaflet procedure was performed, and I find that closing the anterior septal commissure is quite good manners to control the prolapsing leaflet. And had a good result. The second issue was how to manage the type 3B mechanism. When the right atrium and right ventricle dilate, the leaflet tethering occurred. And then the Cleveland group showed the tethering distance and the tethering area is the very strong predictor for the residual TR. When the tricuspid annulus was dilated, as the main dilatation points or parts were anterior leaflet, and then the anterior papillary muscle is causing the tethering. That's why I thought it is reasonable to enlarge the anterior leaflet in these situations. And then Dr. Dreyfus reported the anterior leaflet augmentation to treat the severe functional TR. This is a drawing from his paper. The autologous pericardium was used to enlarge the anterior leaflet. I started to use this technique from 2012, and then I did 3 cases using the pericardium to enlarge the anterior leaflet. But unfortunately, case 3 had a little bit trouble because of the thickened autologous pericardium that caused functional tricuspid stenosis. And then this patient ended up to have permanent hemodialysis to control the heart failure. I looked for the better materials and then found that Professor Yamagishi's technique, he used 0.1 millimeter PTFE materials to use the fan-shaped valved conduit to reconstruct the right ventricular outflow tract. The 0.1 millimeter EPT-PTFE patch is proven to be covered by the thin fibrocollagenous tissue without evidence of inflammatory cells or thrombus in the histological examination, and have been found to be covered by the thin fibrous tissues without evidence of calcification. Immunohistological analysis has revealed focal region of endothelialization. So I decided to use the 0.1 millimeter EPTFE patch and enlarge the anterior leaflet only, and then the suture was interrupted and the running mixtures. I want to share the one case. Patient had severely dilated right atrium, left atrium, and having the torrential tricuspid regurg. The typical finding is interleaflet gap on the preoperative echo that causes the torrential TR. This is one example of this technique. This patient had the previous pacemaker lead, but which is not interfering the leaflet motion. But this patient had the severe RA and RV dilatation. So I marked the commissure between the anterior leaflet and the posterior leaflet, and then the detached anterior leaflet from the annulus. And the annular stitch was placed, and then gap where the anterior leaflet was detached was sized with the MC cube sizer, and then 0.1 millimeter Gore-Tex patch was sutured with the 6-soprolene sutures. And the same size of the ring was used with the gap, and had a good result. This post-op echo showed the TR is well controlled. The indication of this technique is interleaflet gap at systolic phase in a preoperative echo. The patch material was 0.1 millimeter EPTFE patch. I used the 6-soprolene sutures. Size of the patch was decided sizing the size of the defect where the anterior leaflet was detached from the annulus and the annular stitch was placed. And then the ring was 3D shaped rigid ring. The size of the ring was the same size of the patch. We had 17 cases in 6 years, about 4 years period. All patients had the severe TR with interleaflet gap during systolic phase. It's tend to have senior people. The AF is quite common, have the long AF durations, mean of almost 14 years. The half of patients had the cardiogenic, cardiac origin liver cirrhosis, child B, and of course, those are quite symptomatic. All patients had the concomitant procedure. The intraoperative measurement showed the RA and the tricuspid annulus was quite enlarged, and the link used was mean of 32, which is quite a big size for the Japanese population. There was no early mortality, but had one in hospital mortality, but the reason of death was not cardiac origin. She had severe cord aggregation reaction, and then she died because of this. There are the 2 mortalities. The one is third time redo isolated tricuspid valve surgery. She could not live long due to the RV failure, and one patient died unknown reason. All patients had very good control with the tricuspid regurgitation without increasing the pressure gradient across the repaired valve. So I think it's 0.1 millimeter EPTFE patch to control the severe heart failure is one of the good options. Of course, we need a long-term result. So in summary, rigid 3D shaped annuloplasty ring provided a good early and mid-term result. And the repair strategy always has to be assessed by the Carpentier's classification. And then the type 3A and 3B regurgitation is difficult to manage with the isolated tricuspid annuloplasty, so we need additional procedure in addition to the ringed annuloplasty. Thank you very much for your attention.
So now the session is open for questions and discussions, please. I congratulate you. That's a very complex one. And I just one technical question to have your opinion. We found sometimes it's very complex, and we have usually is associated with complex mitral side that we spend a lot of time. Now for the tricuspid, we try to do something, and it still not work for some time. And we, in recent year, about a few years, we use the alveolar stitch to do in the very huge tricuspid, and to just to tie it over and then allow us to go ahead. And we measure it, the mean gradient across the tricuspid valve, almost all is very low, about 3 to 4, but it's very quick. What is your opinion on that?
Personally, I've never done that, but I think that is one of the options to shorten the cardiopulmonary bypass, and then could be the very good maneuver. I've never done it before.
Yes, please.
Thank you for a very nice presentation. And so we have no experience with Gore-Tex, the thin Gore-Tex for the tricuspid valve, but it's certainly very attractive. And since many of these patients are reoperation and autologous pericardium is thickened, and so it would be. Do you have any experience with this for endocarditis?
In an endocarditis situation, I use the autologous pericardium because that patient had very thin pericardium, and I think autologous pericardium is safer in the endocarditis situation. So I've never used this material for the endocarditis patient, but I think if the infection is controlled nicely with antibiotics, certainly this is going to be one of the options in particularly the lead situation with the thickened pericardium.
We have seen a couple of recurrent endocarditis with autologous pericardium reconstruction, so it's certainly not absolutely resistant to it. And so, one point about the alveolar stitch that I can make, that in one period it was fairly popular at the clinic, but we've totally abandoned it. It just doesn't work, and it often doesn't hold up. So we're not using it anymore.
One technical comment or questions. I'm not, in my experience, I'm not always satisfied with the augmenting only the anterior part of the tricuspid with pericardium. So now, more and more, I'm augmenting the anterior and the posterior. So we have to, as said by Tawi, that the commercial things are really moving very well. So, I mean, I had some stenosis, but by augmenting only the anterior without touching the posterior, because it is not moving very well. Can you comment on that? So I'm more and more augmenting both anterior and the posterior. So we have this kind of motion restored and accepted. Can you?
The third case I presented with autologous pericardium, in that case I cut out from anterior to the posterior, and then the thickened pericardium had another, disasters to create the functional TS. So I decided not to cut the posterior leaflet, but recently I'm using a little bit bigger patch to enlarge the anterior leaflet. So without cutting into the posterior leaflet, if you use a little bit bigger anterior leaflet, probably the coaptation length is going to be longer without causing the functional stenosis. That's I think.
Yes, please.
Yeah, one more question. Do you do anything to the papillary muscle? When the RV dilates, of course, the papillary muscle gets displaced in different direction, and so One thing that I have been looking at recently carefully is tied to mobilized the papillary muscles to get the attachment deeper into the ventricle, and I have a sense that that can sometimes be very effective.
I think it's one of the very good technique. And then the Professor Aishi at Nagasaki University in my country is called spiral technique to suture the anterior leaflet towards the septal annulus. I think it's very, very good technique, but sometimes the papillary muscle is a little bit thinner and weaker than we expected, and then maybe tricky. But I think it's certainly one option.
The microphone too, please. I'm sorry.
Thank you, sir, for the nice presentation. Actually, I have a similar case after going back of type 3B tricuspid regurgitation. Just wanted to ask whether Dacron patch will be, Gore-Tex patch will be your first preference, or a pericardial patch will be your first preference for augmentation of the tricuspid leaflet. And second thing is, you showed that the pacing wire, the pacing lead, you embedded inside between the leaflet and the annulus. Would it be a nice idea to put that lead into the coronary sinus?
Regarding the pacing lead position, there is, I think, enough distance from the tricuspid annulus and then the coronary sinus. There is a muscle between that. Yeah. I embedded the pacing lead into that muscle, so I don't think any issues of the coronary sinus. And then the first question was?
Putting it electively into the coronary sinus rather than just keeping it there between your repairs.
I've never done that.
Thank you. Scott, please.
Regarding the Gore-Tex patch and the pericardial patch, what will be your choice of patch if the pericardium is available?
As now, if there's no contraindications of using the Gore-Tex patch, I use a Gore-Tex patch.
Yes.
Thank you.
Scott, please. I have the last questions.
We must remember also that some patients have leaflet prolapse, and I have 2 patients in a video on tricuspid repair on CTSNet where we did artificial cords to the leaflet after the ring was in. Now, and I really like the augmentation also in the patients with tethered leaflets. I have one patient on that video where both leaflets have been augmented. Am I wrong in thinking that the congenital surgeons are saying now that thin Gore-Tex calcifies?
I think if you use a thin PTFE patch, like 0.1 millimeter, the calcification is, I think, less.
But they were using it for outflow tract reconstruction, making valves, and I think it calcified. Is that wrong? Are there any congenital surgeons in the audience?
The Yamagishi group reported the 10 years experience of it, and then the anterior leaflet is only part of the leaflet was calcified, but I think overall valve function is preserved in 10 years' time that they reported.
Okay. Thank you very much. I think we have to end the session because they are going to rearrange the room for the presidential address. Thank you so much for this very fruitful session. Thank you so much.